Hello, my name is David Erlinge. I'm professor of cardiology in Lund University in Sweden. It's a pleasure to be invited to this extremely interesting session about vulnerable plaque treatment and detection. And I have the privilege to talk about identification of vulnerable plaque from Prospect to LRP and Prospect 2. These are my disclosures. So what is a non-flow limiting vulnerable plaque? It's of course a plaque that does not reduce the flow when you measure with pressure wires, but it will cause a coronary event. So using FFR or the other IFR, DFR, RFR can by definition not detect a non-flow limiting plaque, vulnerable plaque. We need other methods to detect these plaques. And it is important because if you look at patient that has been examined with pressure wires and they have undergone a deferral, that means that the pressure wires did not find any plaque that was significant, yet the next 4 years they will have a MACE rate of more than 25%. This is data from our Sweetheart register, which is a nationwide register that can follow all the patients in Sweden. So it's a big problem. It's not enough with pressure wires. And if we come to imaging and detecting the vulnerable plaque, the pivotal study Prospect was a game changer when it came and could detect non-culprit lesion and culprit lesion related events. They did IVUS of all the 3 coronary arteries and found approximately similar numbers of culprit and non-culprit lesion related events. When they looked back in their imaging with the IVUS, they could see that plaque burden was the most important factor for predicting a future MACE. And this would be confirmed in the prediction and VIVA trials and recently in the Prospect 2 trials. And these plaque with plaque burden more than 70% are actually quite common. Nearly 1/3 of the patient had one of those. And if you look at the event rates, if you have no or less than 40% plaque burden, nothing happens. It's first when you come up to 60 to 70% plaque burden that the event rate starts to rise. They also used something called virtual histology and could identify a high-risk plaque called VH-THICVA. Even though plaque burden, more than 70, was the most important factor with a hazard ratio more than 5, VH-THICVA had a hazard ratio of 3. So it could be interesting. However, the problem with this technology is that it's very, very difficult to make an interpretation of these images. You need a core lab and very specialized people. An ordinary PCI operator cannot do this analysis. So it's not very practical to use in the cath lab. We also had MLA less than 4 square millimeters. That was a factor. Furthermore, if they combined and patient had more than one of these plaques, the risk increased from 5 to 18% if they had 3 risk plaques. But we need an imaging tool and a vulnerable plaque definition of a lesion that operators in the cath lab will be able to identify. And now we have something called near-infrared spectroscopy. So it's based on detecting lipid and cholesterol in the human coronary arteries, and it has been FDA approved for doing this. And the reason is that we know from autopsy studies that plaques causing MI and sudden cardiac death commonly contain a lipid-rich core. And now, as I will tell you about, we have retrospective reports and 2 prospective studies that illustrate that this technology really can detect vulnerable plaque that will cause events in the future. It's based on a catheter that both gives away near-infrared light and an IVUS. And it's rotated in the coronary artery, and it expresses if there is cholesterol in a chemogram, where yellow is lipid and red is fibrotic tissue. And a very practical way of expressing is something called max LCBI 4 millimeters, which is those 4 millimeters in the coronary which had the highest content of lipid. And here in this example, you see the rectangle of 4 millimeter here in the chemogram to the left. It has 625 in max LCBI. So that is 62.5% yellow dots in this area. So approximately 62% lipid in that plaque. And we have several observational retrospective studies from different labs. We have from Seroy's lab in Netherlands, 2 labs in the US, Matter and Brilakis, and from my own hospital in Sweden. So, and all of these trials show that if you have lipid-rich plaques based on NIRS, then you have a much worse prognosis and much higher rates of MACE. But we need prospective trials, and the first of those was the LRP study run by Ron Waxman and published in Lancet last year. So here they screened a lot of patients and ended up with 1,552 evaluable LCBI plaques. They kind of enriched this population by taking those with more than 250 in max LCBI and matched them with a similar number of patients with less than 250 in max LCBI. They did the analysis not on a lesion or plaque level, but in wear segments that are 3 centimeter long segments in the coronary tree. They found similar number of non-culprit and culprit MACE, nearly 9% of each. And when they divided them into max LCBI more than 400 or less than 400, you could see that the event rate on the patient level was 13% if you had a high lipid-rich plaque, but only 6% if you didn't. On the lesion level, the difference was even bigger, 3.2 versus 0.8%. So max LCBI strongly predicts MACE both at patient and segment level. They put these results into a multivariable adjusted model, and the results were still significant and a hazard ratio of 4 for max LCBI. They did different analysis of plaque burden, and in some of those analyses it was not significant. But we should discuss a little bit how they did the analysis of plaque burden. But they could clearly show that max LCBI more than 400 was a very important prognostic factor. With regards to plaque burden, in the prospect study, the first one and the second one, IVUS of every 1 millimeter of the entire coronary artery was examined in the core lab. However, in the LRP study, they only analyzed plaque burden if they had a positive NIRS signal, if they had a lipid-rich plaque. All the other areas were not analyzed. So we did the Prospect 2 study, Greg Stone and myself, a natural history study where we had 902 patients with a non-STEMI or STEMI, and after successful PCI, we enrolled them to be imaged in all 3 vessels with IVUS and NIRS, and the NIRS imaging was blinded. 4 of the patients did not yield any imaging data, so they were excluded from follow-up. So we had 888 patients. We also had embedded a treatment trial, the Prospect Absorb trial. So 182 patients went into that one, and 93 were randomized to absorb treatment of the lesion. And those 93 were not followed in the Prospect 2 study. Then we followed these patients for a median of 3.7 years. So we did imaging of 2.7 vessels per patient, which is quite a lot, and 22.4 centimeters per patient. We found 3,629 untreated non-culprit lesion plaques with plaque burden more than 40%. On a median, there were 4 such plaques on each patient. 24% of them was high lipid-rich plaque, as we defined it as the upper quartile, which is more than 325 in max LCBI. So slightly different from the 400 used in the LRP study. 22% had a plaque burden of more than 70% in the lesion, and 38% of the lesion had an MLA less than 4. If you look at the patient level, the numbers get even higher, where you have 59% of the patient had a high lipid-rich plaque, and the same number, 59%, had a plaque burden plaque of more than 70%. And as many as 76% had an MLA less than 4 somewhere. MLA less than 4 square millimeters is a little bit difficult to look at, because if you move your catheter very far out in small branches, you will always find MLA less than 4 square millimeters. This is an important point, and that is imaging-related adverse events. Because if we want to screen for vulnerable plaques, we have to have very safe imaging. We cannot cause harm to the patient. And in the Prospect 2 trial, we had only 0.2% events. And some of those we have them listed here. One of them was treated with POBA very simply. The other one was not related to the catheter at all. It was an air injection, totally unrelated to the catheter. So we had a MACE rate of 13.2%, 8% were non-culprit MACE, and in difference with the 2 previous trials, we had a very low culprit lesion-related MACE, 4.2%. And this is important if we want to start treating non-flow limiting lesions. Then we need to have a very low culprit lesion-related MACE. We can compare the studies like here, and if you look at non-culprit lesion MACE, in the first Prospect it was 11.6%. In the LRP it's 8.8, in the Prospect 2 8.0. This is probably a reflection of treatment in time and better secondary prevention. Culprit MACE was reduced from Prospect to 12.9%, in LRP 8.7%, and Prospect 2 only 4.2%. And adverse events were relatively high in the first Prospect, probably because of a bulky catheter. But now with the improved catheter types, both the LRP and Prospect 2 trial had very low adverse events. And the events were important, hard endpoints, myocardial infarction or progressive angina that led to required revascularization. So I would say that these are important events for the patient. We found 78 first non-culprit lesion MACE events, and 44 of them were imaged at baseline with nearest IVUS. All of them had plaque burden of at least 56%. So if you have plaque burden less than 56%, nothing happens. And nearly 70% had high lipid-rich plaques of these. Here is a typical example. It's a non-culprit lesion, 1 and 2, and the first one comes back 3 years later with a non-STEMI and close to an occlusion, 99% stenosis. And when we in the core lab went back to the blinded imaging done at baseline, we see that this was a lipid-rich plaque with max LCBI of 687. The plaque burden was 80%, so it was really a high-risk plaque. So we found that if we had high lipid-rich plaque with plaque burden or max LCBI more than 325, the patient level risk was increased by 2.08 in odds ratio, and the lesion level was increased by 7 or even more in odds ratio. For plaque burden, we could confirm the first Prospect study with odds ratio of even 3 in patient level and 11 on the lesion level. The MLA had a very high odds ratio of 5 on the patient level, but only 5 on the lesion level. So there is MLA for square millimeter is a little bit different from the other parameters. And you can see that the increase in risk was regards to high-risk important factors like myocardial infarction and progressive angina that required revascularization for all the 3 high-risk criteria. So if we put these criteria into a multivariable model, you can see the clinical factors that we put in the lower left. All of these 3 high-risk criteria are highly significant in both patient and lesion level models. You can see the p-values of 0.00 something. And if we put in to this multivariable model also the high-risk criteria in the model, something happens. It turns out that the max LCBI and plaque burden are still highly significant with odds ratio of 4 to 5, but the MLA actually becomes non-significant. There is still probably some predictive value in it, but most of the predictive value is explained by plaque burden and max LCBI. So what happens if we combine these two? We say we want to have the plaques that have both a high plaque burden and a high lipid content. And then the risk increases a lot. Then on the lesion level, it's 7% risk. And very interestingly, if you look here, you can see that if you don't have plaque burden and you don't have high lipid, nothing happens, a risk of 0.2%. And on the patient level, the combination results in 13% versus 5% in event rate. We also present as a secondary analysis using more than 400 as a cutoff, like they did in the LRP and in some of the observational studies. And then the risk increases from 7 to 8%, and on the patient level from 13 to nearly 16% in event rate. So you could use the 400, you get more specificity, but you will find fewer plaques that can cause event in the future. I think it's important to compare the LRP and Prospect 2 trials, because we know that to get an 1A in the guidelines, you need 2 good prospective blinded trials to show us rather similar things. And if you look at these graphs where we put in the 400 cutoff from in the Prospect 2 trial, you can see that they are extremely similar. In the LRP, 13 versus 6%. In the Prospect 2, 12 versus 5% on the patient level. And on the lesion level, we have 3.2% versus 0.8%. And in the Prospect 2, 5 versus 0.6. So these 2 trials really confirm each other in that max LCBI and high lipid-rich plaques are dangerous. You can also express it like this. We divide the patient into levels of max LCBI in 100 groups. So 0 to 100, 100 to 200, 200 to 300. And then when we came to 600, the groups became so small, so we lumped together all the groups 600 to 1000. And you can see that the higher you get in the max LCBI, 4 millimeter values, it starts to increase at 300, and then it increases exponentially as we go higher up in the max LCBI. So I think this is very strong evidence that a lipid-rich plaque detected with NIRS is a dangerous thing that we need to discuss if we should treat it in some way. So my conclusion is that Mason angina is common even after FFR or pressure wire deferral. Vulnerable plaque, non-flow limiting plaque that cause future events are common. There are intracoronary imaging methods that can reveal vulnerable plaques as proven in prospective trials. The IVUS detected plaque burden more than 70% has been proven in the Prospect trial, the VIVA trial, the Prediction, and now the Prospect 2 trial. And NIRS lipid-rich plaques have been proven in both the LRP and the Prospect 2 trial. The Prospect 2 trial is in press in Lancet, and the LRP was published in Lancet last year. So pressure wire, FFR or IFR, DFR, RFR need to be combined with intracoronary imaging in order not to miss any of the vulnerable dangerous plaques. And the most vulnerable plaque is a plaque with both high plaque burden and high lipid-rich content. So thank you for your attention.